The information shared on this podcast is for educational and informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay seeking care because of something you heard on this podcast. The views and opinions expressed by guests or hosts are their own and do not necessarily reflect the official policy or position of any affiliated organizations. Reliance on any information provided by this podcast is solely at your own risk. Welcome back to the Healthy Image Podcast, where we bring you real conversations with the people behind the images that help guide patient care every single day. I'm your host, Veronica.
And I'm your co-host, Stacy.
Today's episode is all about stepping inside one of the most advanced imaging modalities in medicine, MRI. We're joined by Tom, one of our talented MRI technologists here at the Huntington-Hill Imaging Center in Pasadena, who plays a critical role in capturing the detailed images physicians rely on for accurate diagnoses, from brain and spine studies to orthopedic and soft tissue exams. In this episode, we'll talk about his journey into MRI, what makes the culture at Huntington-Hill so special, the types of MRI studies he performs, and we'll answer some of the most common questions patients have, including how to prepare for their exam. Let's get into it. Welcome, Tom.
Welcome.
We're so happy to have you here today, and thank you for joining us.
My pleasure.
So I do want to get into a little bit about why you got into MRI. Can you introduce yourself and what you do here at Huntington-Hill Imaging Centers?
Yeah, my name's Tom Macias. I'm one of the senior MRI technologists here at Huntington-Hill. I've been with Huntington for about 15 years, a little over 15 years.
Mm-hmm.
I specialize pretty much on everything that there's to do in MRI. I like and I thrive on some of the more advanced exams that we do.
Mm-hmm.
I also like doing some of the research stuff that we do. I headed up most of the research things that were done at Hill.
Mm-hmm.
And that's pretty much what I do here at Hill.
What would you say first inspired you to get into the field of radiology or medical imaging?
How I got into it
How did
was
you
kind
get
of
into this?
it was kind of a long story. I was going to college at the time, and I needed a part-time job just because I was playing football. And so on my off time, I needed to make a little extra money. And my best friend's mom's
Mm-hmm.
best friend's boyfriend was a technologist.
Okay.
So if you go there, and they needed a tech aide,
Oh.
and it was in CT.
Mm-hmm.
So I said, yeah, I'll go at it. I was kind of in pre-med. I was taking all the anatomy. And
What were you going to school for?
I was thinking of going into med school. I was
Okay.
thinking about that. And I was really intrigued in that field. And so being part of this was like, oh, that'd be great.
Yeah.
I'd love to do that.
It's like an intro to everything.
Yeah.
Mm-hmm.
So I got into it, and I did most of the filming for
Mhm.
CT and setting up the patients and doing everything that needed to be done. And at one point, MRI came about,
Oh, okay.
and they said, hey, Tom, you know how to do everything. You just can't, you don't have a license to do
Mhm.
this. But in MRI, there's no radiation. Would you be willing to learn?
Mm-hmm.
And then you can start scanning MRI. And I say, okay.
Yeah.
So I did.
So they basically cross-trained you from CT to MR because
Yeah.
you were so good at your job.
Pretty much. Yeah. They knew what I could do.
Mm-hmm.
Then as the licensing came about, they asked me to go and get an x-ray license, which I
Mm.
did. I got limited in that. They asked me to, when ARMRIT came about, get an ARMRIT license.
Mm-hmm.
So I got that. And then not too long ago, I got my ART.
Mm-hmm.
And so that's how my schooling got. And then I also completed my bachelor's degree. And so I was able to get that. But that's kind of really how I got into it. I
Mhm.
really got into the an MRI in the infancy of MRI, you
Yeah.
can say. So it really was a challenge because you had to figure a lot of the stuff out yourself. There wasn't anybody to really kind of explain everything.
Yeah.
I actually sat in a conference with all the radiologists that I was working with, and they were learning MRI, and so was I.
Yeah.
Wow.
And that's how I got my first schooling of it. And it was kind of it was a little overwhelming at
Yeah.
first, but then, I went back and I got books and I was reading up and I was trying to understand it and, the physics of it all. And I did. And it helped me, and it kind of propelled me into how to do more in MRI.
Yeah.
And as things advanced, as scanners advanced, as technology advanced, especially in the infancy, it was leaps and bounds. Every few months, something new was coming out in MRI. Right now, there's the new isn't so much as the techniques; it's the actual like image quality, where you can enhance the images better or make them faster. And there's other little things here and there that you can do. But at the beginning, it was like, oh, we did T1s and T2s, which is a type of technique, which then went into a stir, and then which went into DWI, and then went into other things that, flares and, different types of techniques that were just, oh, what's this? Oh, it can do this too. And, they, as people, as physicists and PhDs and doctors were learning the different things of what can happen within MRI. They were starting to apply, oh, let's try. There's more and more to do. Whereas now, they found all the different things that they can do. It's more of refining in it and making it better or faster. So that's how I guess where MRI is kind of at the point right now.
Would you say it takes like some special skills or qualities for someone to do MRI? If it's someone that's never done MRI or was thinking of getting into MRI, what kind of skill set do you think they need?
MRI, it really, you have to be able to understand what happens to the anatomy inside when you're going inside a scanner. It deals with the protons of your hydrogen atoms, and which you find in what is mostly in our bodies, which is in the fat and water of our bodies, and our bodies are primarily made up of fat and water, which is primarily what the hydrogen is in, and how we manipulate those protons to get off signal, and how we can get certain signals to be brighter or darker based upon the technique that we're using to manipulate or knock down the protons. So the more and more you get into the field and to understand that helps you to be a better tech. Not everybody can understand that at first. It takes a little time. It's not to say that no one can do it. It just, some people grab it right away, and others, it takes a little time. And I see that a lot teaching. I teach MRI. So in teaching, I see certain students that pick it up right away and just understand it. And then there's other students that I'll have to tutor at times, and I'll make different analogies and different things, and how signal to noise or things like that work, and then they can understand it in more layman's terms and then put it into what they're doing. So it really depends on, how people grasp it at quicker or slower. But most people can get it at one point.
Yeah. Just depends on how quick they get it or
Yeah.
not. Yeah. How long have you worked here at Huntington-Hill?
15 years. I started 1989.
Wow.
I won't tell you that that's the year I was born.
No, it's okay. Yeah. No, I was really young at the time. I
Yeah.
started when I was
When you were,
5.
yeah,
Yes.
that tracks. That makes sense.
Yeah.
Um,
You look great.
how would
Thanks.
you describe the work culture here at Huntington-Hill?
The work culture here, it changes all the time.
Yeah.
You know, it's never really the same. You know, you have a group of people that you're working with, and then all of a sudden they go on, they move on, and then you get a whole different set of people in there, and the dynamic changes, and it's always changing. But it's not for the worse or the better. It's just different,
Right.
you know. And I would say, like, you know, working with certain people that are still here, that are here in corporate, that I know and I used to work with and have a great time with. And their personality is different from some of the people that I work with now that I have a great time with and
Yeah.
get along with well. So I can't to say that it's just the different dynamics
It's
of
just
it.
changing.
And
Yes.
I like to be able to assert my personality into the whole situation.
Yeah.
And my personality is usually to have a fun atmosphere when you're working, because the least amount of stress and the more at ease people are at, the more they're able to focus on what they're doing
Yeah.
rather than being so stressed out that they can't.
Yeah.
They-
That's when mistakes happen.
That's when mistakes happen.
Yeah. And you spend a lot of time at work. You might as well have fun.
Yeah, and that's true. And you're going to be spending 8 hours with these people
Yep.
a day.
And
more
the
than
patients that are coming in,
yeah.
more times than not, they're stressed about something. They're coming in
Yeah.
to be diagnosed with something
Exactly.
potentially. So they would probably feed off the fun energy too. It probably helps put them at
Yeah.
ease a little bit too.
And that's one of the most important things. You do want to be able to get your patient and bring them in and make them feel comfortable.
Yeah.
They're stressed. Some people are very nice and kind and they're more relaxed. Some people are grumpy and just
Or claustrophobic, so they're nervous. And
or not. Yeah. And you just have to deal with how and kind of react to the way they are. And, you know, I'll get a grumpy person and next thing you know, they're laughing.
yeah.
Yeah.
Or I'll get a person that's joking around and they're, you know, you just have to joke around with them a little bit,
Yeah.
you know? And it's everybody's anxiety, you know, especially in MRI. Some people will read about or hear horror stories. Oh my God, it was the worst experience of my life. I was shoved in a tube and the whole thing, and they're just worried, and you can tell when they you know which ones they are. They have to go to the bathroom, then they have to drink water, and then they have to go. Oh, I left something in my a ring. I'm gonna put it away, and then they're making excuses to stall the exam.
Yeah.
Yeah.
And you can tell and you can see where the anxiety is coming. So the more you kind of put them at ease by explaining to them what's going to happen, by showing them the equipment, that's a huge thing. And I try to show the other techs, walk the patient around. I always say, here, let me give you the grand tour. And I show them the whole scanner. I show them that it's open on both sides.
Yeah.
And they really calm down. Oh, I didn't realize it's open. Oh, yeah, it is. Or they're in the scanner and I said, look back, you can see out. And they go, oh my God, okay, I'm good.
That
You
gives
know?
them like a sense
Yeah.
of relief.
Yeah. So, or they're not in too far and their hands are barely sticking out and you can just touch their hand. Look, your hands aren't even in. And they're going, oh, okay. And, you know, just that little touch
Yeah.
will just put people at ease. So, but the environment of the whole facility really works on how everybody works together.
Yeah.
And I try to make it as fun and more as relaxed as possible.
Yeah.
So,
Yeah. Is there something that makes Huntington Hill unique compared to other places you've worked?
Yeah, I mean, in certain aspects, it is. It's a lot has to do with me and how I like to be work in
So
my
what you're
work
saying
environment.
is you are what makes Huntington-Hill unique.
He's
In-
like, I'm that guy.
yeah. Well, in a sense, yes. And as everybody is there, if I'm not there, a different personality will be there, or in a different tech. So the dynamic changes every time there's a different person in there, a different personality. As far as that's concerned, I think it's a great environment. I mean, the facilities, it's a great looking facility. And one of the things about having a beautiful facility like we do, beautiful walls and the scanner and everything really looking nice, is it puts patients at ease. Well, you go into a different facility, and I've worked at other facilities. I worked at hospitals. It's all white, and it's just,
Yeah.
It looks very sterile.
it's
Yeah.
very sterile
Cold.
or cold.
Yeah.
It's just, the floors are just nothing, and the walls are just bare, and
Yeah.
just just equipment around. If you think about yourself as a patient going into an environment and you sit there, you're going to get a little tense.
Yeah.
It's like, ooh. But if you go into an environment like what we have at Huntington-Hill, it goes, oh, wow, I feel like I've had people say, I feel like I'm in a hotel, which it brings down the anxiety.
Yeah.
Yeah.
And that's the other thing is how I work and I stress with the other techs is keep the room as neat and as clean as possible. Because if a patient comes in and they see things all over the place, they're going to go, ooh, and then their anxiety goes up. Where if they come in, they go, oh, wow, this is beautiful. This is so nice. Their anxiety comes
They're
down.
relaxed.
Yeah.
And
They're relaxed.
They're relaxed and they'll
And
listen to you.
And especially in MRI, the most important thing is to bring anxiety down because it is kind of a stressful exam for a lot of people.
Yeah, and they have to control their breathing, and it's hard to control your breathing when you're stressed
Stressed
out.
out.
Yeah. Do you have patients that confuse you for a radiologist?
All the time.
Yeah.
They'll call me doctor.
Can you explain the difference between the technologist and the radiologist?
Well, first of all, the technologist is not a doctor. We cannot diagnose anything, and we cannot say anything that we see on the scanner, on the images. Doctors obviously go to med school. They become a doctor, and then they go into the radiology program. So they're MDs, and they can prescribe medication. They can handle the medication. They can tell the patient what's going on. We're not licensed to do any of that.
So you're taking the picture.
We're the eyes for the doctor. And so that's one of the things that we have to remember. If we don't see it, don't expect the doctor to see it. And that's what I stress with a lot of techs or even the students.
Yeah.
When I'm with students, make sure that you can see what's going on. You can identify things that need to be identified. Because if you can't see it, they're human too. How are they going to see it?
Yeah.
Right.
So if your images are blurry and you can't see and you're trying to go, oh, what is that? Well, that's what the radiologist is going to do.
Yeah.
I can't see that. And what is that? So, or if you see pathology, maybe you want to do an extra scan just to make sure you verify that that is what it is. Because the radiologist is going to go, God, I wish you did,
Extra slices.
an extra slice through here or an extra sequence through there so that I can see it a little better. So I will do that as a tech. And I will, students, I teach them that. And even the techs that I work with, go ahead. It's okay. And, told the tech today, she goes, I'm cutting this off. And I go, it's okay. Increase the field of view. It's okay if it's not what's set in the computer doesn't mean that's the only setting.
Yeah.
You have to change things as they go along because one of the things is no person's body
Is the same.
is the same.
Mm-hmm.
Everybody's bodies are different.
Yeah.
So scanning my arm will be a lot different than scanning one of your arms,
Mm-hmm.
because mine are twice as long,
Yeah.
you know. So it might be a little bit more difficult
Mm-hmm.
because I have to cover more.
Mm-hmm.
So you have to alter things. Or if I'm scanning a child, which is a tiny little, small area, I might have to adjust down so that
Mm-hmm.
I'm not doing a scan like I would an adult,
Yeah.
because you're going to be you might miss something.
Yeah.
It's like maneuvering the body part so that you can get the actual scans. Since you are the eyes,
Yeah,
you can first-handedly see the patient, so you have to adjust the field according to patient.
exactly.
So, how closely then do the techs and radiologists work together? And do you feel like that relationship impacts patient care?
Yeah, and it really comes down to the technologists as well. Um, Sometimes it's up to the technologist to be able to say, look, I see something here. Getting the eyes of the radiologist to
Mm-hmm.
go ahead and verify and say, look, I see something here. What do you think? Is there something else you want me to do or whatever?
Mm-hmm.
They're almost always willing to say, oh, yeah, let me see. Can you do me
Mm.
that? Can you do this? Or, no, that's fine. That's
Mhm.
good. You got what I need. That's all.
Is that typically like during mid-scan, or is it towards like after you've scanned additional imagers
It
that
could
are
it could be
needed?
anything.
Okay.
It could be any time. Usually, I try to do that while I'm doing in the middle of the
Mm-hmm.
scan. Otherwise, because we are on a time constraint.
Mm-hmm.
We have scheduled patients,
Yeah.
so we have to do all our work within that
Mm-hmm.
time frame. So, but when in doubt, call the radiologist.
Yeah.
Yeah.
That's the most important thing. And so, working with a radiologist is extremely important, especially when it comes down to working with the patient.
What exactly is an MRI, and what should patients expect?
Okay. So, what an MRI is it stands for magnetic resonance imaging. So, as if I say to my students, who can tell, I pose that same question as
Mm-hmm.
though I was a patient, and I ask my students the same thing. And I say, if you can do it in 30 seconds, you know exactly what's going on,
Mm-hmm.
because that's all you have. So, the answer is magnetic resonance is, it uses your body, the fat and the water of your body,
Mm-hmm.
the protons of your hydrogen atoms. So as you go into the MRI scanner is a huge magnet. And when you put your body into the scanner, those protons align to the magnetic field. Okay. And they're kind of rotating and spinning just along that their own axis, because as they spin around, they're in their own little teeny little magnets themselves. So what we do is we send in radio frequencies and or alter the magnetic field using gradients. And what we do is we knock down those protons. Now we turn it off. And we turn it off, those protons realign back to the magnetic field. As they do that, they spin back up and they resonate and they give off a signal of their own, a radio frequency of their own. Now, the thing that if you're doing a head, you're going to be in a head coil. If you're doing a knee, you're going to be in a knee coil. If you're doing a torso or anything, you're going to have something around you that's going to pick up the signal.
Mm-hmm.
Those are the coils.
Mm.
They're antennas
Yeah.
picking up the radio frequency your body's giving off. That we send that signal into the computer. It puts it all together and creates an image.
Mm.
Now, you got to remember, every part of your body has more hydrogen consistent than other parts. You have air, which has none. You have muscle that has less, fat that has more. So the more signal. The less signal. So there you have your variations of signal intensity. So you can actually create an image if you're just slicing the person open
Mm.
based upon how much hydrogen is in that area.
Interesting.
So there's no photons, there's no X-ray or radiation involved in it. So
it's a big magnet. So what
Huge magnet.
happens if somebody walks in with something metal?
Well, if it's ferrous. It should be attracted to the magnet and go into the magnet and can become pretty dangerous, a projectile.
Yeah.
If it's non-ferrous, like gold or silver or aluminum, then it's non-ferrous, so it shouldn't be attracted to a magnet.
I have heard that even like if somebody has a tattoo, that like sometimes they'll feel that get hot when they're having an MRI. Is that true? I don't have tattoos and I've never had an MRI. So
that can be true.
Yeah.
And it really depends on the lead content of the dye that, or the ink that they put in. Now, nowadays, they don't use a lot of lead in there.
So it would have been like a tattoo that was done
A long time
many
ago.
moons ago.
Yeah. So a lot of people shouldn't have to worry
Yeah.
about it. And the reason why is because the metal in the ink might heat up.
Yeah.
And that's what will cause the problem.
Right.
Now, back in the day, we used to see a lot of people with tattooed eyeliner.
Oh, yeah.
Like permanent makeup. Facial permanent makeup.
Facial permanent.
I didn't think
And
about that.
there's been a couple times, and I've seen, not recently, but back in the day, where they'd come out of the scanner and their eyelids would be a little swollen. And we'd have to put ice packs on them.
Yeah.
Oh.
Now,
When you say back in the day, like how many years are we talking?
we're
just so the listeners,
We're not trying to
are
age
aware.
you.
we're talking about in the early to mid 90s.
When that permanent makeup was like new and upcoming, and they were
Yeah.
just mixing whatever they were mixing
Exactly.
in there.
Now they don't use that type of dye and
Yeah.
stuff.
See.
It's not. Yeah, nobody wants to put lead in their body.
Yeah.
So
Yeah.
Well, what would you say is the number one question patients ask before their MRI?
am I going to survive?
Is this going to hurt?
No. I guess everybody's so different, but I guess the number one is, how long is this going to take? And I guess because their anxiety is, how long do I have to be in there?
Yeah.
You know, so, and usually for us, they're not long at all, because
Yeah.
we have that Swift, which we incorporate into our images, that helps eliminate a lot of the noise. And so they make the scans a lot faster on certain
MRI studies.
studies, yeah, on certain studies. So usually it's about 15 to 20 minutes per scan. On the body scans, which we don't use Swift, they're usually around 35, 45 minutes, right around to, cardiac studies or, setup time and everything like that, usually over an hour. So, yeah.
How do you reassure patients that the MRI is safe?
I always say I've been standing around this thing for over 30 years, so obviously I'm okay.
You're like, I am the example.
It depends who you ask. I don't know. That could scare some people.
Yeah, that's true.
How do you help patients who feel like claustrophobic or anxious before the scan?
Well, the first thing I do is you identify if they're claustrophobic, because a lot of times they're not going to tell you if you're claustrophobic.
Or they don't know that they're
Or they just
claustrophobic.
don't know. Yeah.
Yeah.
You can tell by the way they start looking around the room.
Oh.
Okay. You can tell by the way that they start asking you questions. And going back to your question, I guess the number one question is, what would happen if there's an earthquake?
Really?
Yeah.
Well, we live in California.
Yeah, that makes sense, actually.
So, I mean, it's a pretty valid
Yeah.
question.
Yeah, it is. And I say, I just keep on scanning.
Mm.
No,
You're like,
I'm just kidding.
Yeah, no.
He's like, I'll pull you out. There's an emergency panic button, and you can push it.
I know they're a little nervous and anxiety ridden, so I joke around with them, and I usually go, well, I don't know. I usually run out the door. And then they're going, huh? And I'm just going, no. Well, obviously, we're going to make sure you're out,
Yes.
and we'll take care of you.
Yeah. How fast can you get a patient out of the scanner?
Pretty fast.
Yeah.
There's an emergency release button. You just slide them right out. You could just
Gotcha.
pull them right out. So it's not
It's not like a.
No, no,
It's
no.
not like a
It's not like
slow.
Yeah.
waiting for it. No, there's an emergency.
Okay.
On all scanners, there are emergency release
Mm.
buttons, and you can just slide them right out, and they just slide right out. So
Well, that's pretty interesting because I think initially when I thought, oh, MRI machine goes in very slow,
I
was
did
like,
too.
I was thinking, oh, it's gonna be like, reversing your car seat, going
Yeah.
very, very slow to go
Yeah.
Yeah.
back.
Yeah.
That's what I pictured.
But
That's good
getting
to
back to
know.
your question
Yeah.
about people who are claustrophobic, like I said, usually what I'll do is I will identify where that they are a little nervous, and I'll just show them their environment,
Mm,
because by being claustrophobic, you're taking away their control.
mm,
It's a control issue,
yeah.
and so and it's all mental. So if you're able to show them that there's an exit,
Mm-hmm.
you can always claw. I always tell them you can always crawl out.
Mm-hmm.
But it's better to squeeze this ball I'm going to
Mhm.
hand you.
Yeah.
So that ball is just control.
Mm,
Now they have control of when they want to stop.
mm,
So you can just squeeze the ball, and I'll pull you out right away. It's a
mm.
lot faster.
Well, that's really
So
good to know because I think a lot of times patients don't actually come in to do MRIs because they're claustrophobic or
yeah,
they know they are. At Huntington-Hill, do you guys provide, I don't know, anything to ease their claustrophobia?
yeah, we do. We provide a little sedative.
Mm-hmm.
That's pretty much it. Just oral sedative.
Mm-hmm.
If there's any thing more than that is needed, we'll send them to the hospital.
Mm,
So we don't want to, we don't have the facility or the life support stuff
Mhm.
there. We would have to call 911 to have them there. We're at the hospital. They have everything right there
Yeah.
for if anything adverse happens. So we give them a mild sedative to help them to relax. Do we do everybody? No.
Yeah.
There are those patients that it's just too much from.
Mm,
Their anxiety is too high. Sometimes we can bring them back.
Mm.
It's just the day.
Yeah.
That day they're just there was too much going on in their lives. Things were going on, like maybe a death, and they
Mhm.
just saw. I've gotten this many times where their loved one or somebody was in a casket, and they're going into
Mm.
this thing, and
Yeah.
they're like, "Oh no, I can't do this.
Yeah,
I
it's
just
very
can't do it."
triggering.
It triggers an
Mhm.
adverse event. Or I have actually had a Vietnam vet
Mm.
who I started putting him in, and he goes, "Please take me out." And I
Mm.
said, "Are you okay?" And he goes, "No, I was a POW,
Oh my gosh.
and they buried me up to my neck,
Mm.
and I had to stay that way for weeks."
Ah,
And so he goes, "I'm sorry, I can't do this."
yeah.
And I was like shocked.
Oh my gosh.
So it was, obviously I'm not going to scan him,
Right. That's a very
but
valid reason to
Mhm.
be
but
nervous.
you do come across a lot of different patients.
Mhm.
I used to see, going back to tattoos, back in when I first was doing it, a lot of Holocaust survivors with the
Mm.
tattoos.
Oh.
And we would have to say, okay, if it heats up, let us know,
Mhm.
Yeah.
squeeze the ball. But you come across a lot of different
Yeah.
people getting an MRI, and they'll tell you a lot of what's going on in their lives or what
Mhm.
they've experienced
Mhm.
and
Yeah.
stuff like that.
Because you have that like personal time with them.
Yeah.
Because a lot of time patients just really want to be heard because
Yeah.
they're going through stuff and they just want to talk to a person that's unfamiliar with them that he can just, release how they're feeling.
Yeah.
Can the
Yeah.
patient talk to you when they're in the machine?
Yeah, they can.
And you can hear them on the other
We can
side?
hear them on the other side. There's an
Mhm.
intercom in all scanners.
Yeah.
There's always something. So you just talk to them and say, "How you doing?"
Yeah.
You're always going to ask them.
And you can hear them if something,
If
Yeah.
they just say stop or, whatever.
Yeah, you
it may
generally
be.
do. But most importantly is you always want to give them the emergency call
Mhm.
button,
Yeah.
and that way it's if they're really having a problem,
Mhm.
they can get your attention right
Yeah.
away.
Yeah.
So,
What should patients do to prepare for their MRIs?
to prepare,
Mm-hmm.
one is try to wear nothing that's has any kind of metal on it or on the
Button zippers,
buttons.
clasps.
Even though at our facility, and should be at every facility,
Yeah.
we should change them and put them into gowns
Okay.
or scrubs. But it's not to say that some people wear different type of underwear,
Mm-hmm.
like sports bras
Mhm.
or athletic shorts for underwear. That can be a problem. So I usually want to have them wear some type of cotton.
Okay.
Mm.
I had a patient probably about a year ago that was telling me, "Oh my God, my crotch was burning," and I'm
Oh,
like going,
no.
"Why?"
That shouldn't happen.
He's in a gown,
Mm-hmm.
and I'm going, "Oh, okay," and I go, "That's kind of odd," and I say, "Are you okay?" And he goes, "Yeah, yeah, I'm all fine. I'm fine now." But at one point, it really started getting hot. And I
Mm.
said, okay. So as he was getting up, he lifted his leg off and the gown lifted up and I can see his shorts. He was wearing
Mm.
athletic running
Oh.
pants, which if you have that type of non-sweat type
Mhm.
of breathable material, they interweave a lot of like aluminum and stuff in there.
Mm.
So obviously he was getting hot due to
Yeah.
the type of clothing that he
The
was wearing.
material was
Mm.
heating up.
Yeah,
So make sure you wear cotton. No
cotton is
zippers.
better. No zippers.
No
Yeah.
zippers and cotton.
Yeah, if you're the type of person that wears a lot of jewelry,
Oh.
try to
Oh.
remove as much of the jewelry as possible.
What
Try
ab-
not to wear it.
What about those? Have you seen people come in with those what are they called? Those bracelets like the
Forever brace,
Yeah,
permanent
yeah, yeah.
bracelets.
forever bracelets? Um, it's if I'm doing the area, obviously we're gonna have to remove it
Okay.
because it's gonna create an artifact and
Mm.
it can cause a problem. If it's not in the area, what I usually do is I'll try to put some type of barrier in between, and I usually put like a tissue paper or something
Oh,
in
okay.
between the bracelet and the
Okay.
skin, so that the skin isn't touching.
Mm.
Usually, it's non-ferrous material, so it's gold or
Mhm.
silver or
Mhm.
something like that. So it's not going to be posing a problem as far
Yeah.
as sticking to the magnet or pulling on them.
But then the patient would then have to know because a lot of these permanent bracelets, they're gold filled, but they don't know what material is inside it.
Exactly. So you just have to either test it or when they
Mm.
first going on, if it moves or something, then we might have to take it off.
Yeah.
So um, usually it's not, as far as I've seen, it hasn't posed a problem,
Mm.
but you never say never.
Yeah.
Yeah.
Yeah. So you just um, take as many precautions as you possibly can,
Yeah.
Yeah.
so nothing will happen.
What are the most common MRI exams you perform?
Brain scans,
Mm.
lumbar spine scans, knee scans, shoulder scans.
Mm.
Those are primarily the most scans that we do. Obviously, people getting headaches or other type of um, numbness in their fingers or hands or double vision or anything, brain,
Mm-hmm.
or memory loss. A lot of memory loss. So brain is probably the number one.
Mm.
After that, it comes down to lumbar spines. Everybody's got a bad back.
Mhm.
Knee, largest joint in the human body, and it takes a lot of abuse. So,
Yeah.
shoulder, you're always using your shoulders.
Mhm.
Yeah.
So those are probably the most common.
Yeah.
And we do a lot of liver and body abdomens.
Yeah.
So we do a whole lot of them at our facility. Not a lot of facilities do as many, but as we do, but we do quite a bit.
Yeah. And is there a certain MRI study that you think requires the most precision or skill to perform?
A highly skilled one would be cardiac scans.
Mm.
There's, when you're scanning a heart, not all the hearts are pretty much the same.
Mm.
They're kind of crooked and they're not shaped the same as everybody else's,
Yeah.
and some are really weird and some
Mhm.
are not. So you have to be able to identify all the 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 ventricles and the
Mm.
atriums and the
Mhm.
you know and the valves and
So
stuff.
very intricate, a lot going on.
Yeah, and we when you're normally doing an MRI, you're going to say I want it in the coronal plane or the axial plane or the
Mhm.
sagittal oblique or something like that. When you're doing a cardiac, we don't say that because your heart's in all different oblique. We're
Mhm.
doing different angles and different obliques all
Yeah.
together, so it's too hard to really
Right.
determine
To
what it
just do
is.
like that one position.
So what we do is they're called um, two-chamber view, three-chamber view,
Mm.
four-chamber view, and a short axis view,
Mm.
so that we understand what
Yeah.
view or what
Because the
chamber.
heart's not staying still, hopefully. You know?
No, the heart's not staying still,
I mean,
and plus it's
yeah.
not in it's not in an anatomical position that
Yeah.
the same as the rest of the body
Right.
because we're doing something that's more intricate.
Yeah.
Because then for the cardiac ones, there is like a prep, isn't there? Like you're supposed to take medication to kind of slow down the heart rate.
That's more for CT
Oh,
than an
okay.
MRI.
Mm.
We sometimes that can help, but we it does have to scan. We do have to scan in between the heartbeats,
Mm.
so we do gate the heart by putting just like a EKG leads on,
Mm.
but we not as many as you would on the EKG, and it's more so that you can scan in between the beats of the heart, in
Gotcha.
between the what we call the R&Rs.
Mm-hmm.
So, because if your heart's moving, you're going to get a blurry image.
Yeah.
So we kind of try to get it in between the heartbeats so it's stationary. And we also have to breathe the patient because your
Mm.
diaphragm's going to be moving. And if they're breathing, it's going to be pushing your heart up and down.
Yeah.
So not only does the scanner have to scan in between the heartbeat beats, we have to tell the patient to not breathe
Oh, yeah.
during
Hold
that.
your breath.
Exactly. So if you ever come into the department
Yeah.
and you hear us breathing quite a bit, it's probably a cardiac scan that we're doing.
Would you say that's one of like the hardest scans to do?
It is when you first start learning.
Mm.
After that, it's not.
Mm.
And it really, it's just like anything else. Once you understand what the heart and the chambers are and
Yeah.
how they look and what they're supposed to do, it's really not that hard.
Yeah.
Mm.
The hard part is when you're dealing with a patient that has like AFib, because now the scanner, if you have to scan in between the heartbeats,
Mhm.
if you have AFib, it's not,
You can't predict when
Yeah.
it's
you
gonna
don't know
be,
when that
yeah.
heartbeat is. So the scanner will start looking for the next beat, and it's like going on. The poor patient's holding their breath for like
Just gonna
25
pass
seconds,
out.
and then they go, okay, breathe. And they go, ah,
Yeah.
so and it slows it down. And also, if it's a slow heart rate, then it's going to be a longer breath hold because it's
Mm.
in between. If it's a
Yeah.
faster heartbeat, then it's a quicker scan.
Yeah.
Yeah.
So it really depends on everything. But so, you have a lot of different things that you have to worry about when you're doing a cardiac scan.
Yeah.
It's just not cut and dry. Okay, hold your breath, take a picture, and you're
Mhm.
good to go.
Mhm.
It's hold your breath, and hopefully the heartbeat's breathing the way it's supposed to
Mhm.
be, and it's working out well.
Yeah.
And it doesn't. And you got to remember, most patients are coming because they have a problem with their heart. So,
Yeah.
poses a little bit of problem sometimes.
When would a patient come in for an MRI versus a CT? What does an MRI show that a CT doesn't?
Well, first of all, CT is a computerized X-ray. So, uh, even though it does show um, uh, good soft tissue detail, pretty decent soft tissue, it's not going to show the same level of soft tissue that MRI is
Mm.
going to show. So, MRI shows more detail in soft tissue
Mm.
than CT will. Though CT has great advantages as far as like being able to visualize the lungs and things like that. Like if we're going in for a screening lung scan because they want to see nodules or something, MRI is not the thing to do.
Mm.
It's a CT scan. If you want to see the ligaments or the cartilage of a knee, CT is not the thing to do. MRI is more important. So but if you want to know the bone, exactly what's happening in the bone, then CT might be better if that's what you're looking for.
Mm.
So CT and MRI complement each other. I wouldn't say one is better than the other. They just really do complement each other, and what you're looking for based upon the patient's diagnosis or whatever.
Mm.
I would probably too, if a patient has some sort of metal implant and they can't have an MRI, now you're having to
Exactly.
look at maybe a CT might be able to show something.
Exactly. And you got to remember nowadays CT scans are so quick,
Mm-hmm.
and MRIs are still very long.
Yeah.
Mhm.
You can get a full CT scan within seconds, and MRI, your seconds is a scout just to find out. Oh, yep, there it is. That's
Yeah.
where I need to start looking. It's not anything
Mhm.
Yeah.
diagnostic.
Are there any MRI studies that you find a lot of patients or even doctors don't know that we offer?
I don't know if I think everybody in our community knows what we can offer, because obviously we have tons of cardiac scans.
Mhm.
We have tons of body scans, and we do a lot of orthopedic stuff, especially with the T3T and stuff. So I don't think we have so many variations of different doctors sending to us, and we're
Mhm.
so busy. I think the community does know. It's what they don't, the thing that they don't know is what we don't do. So there might be certain techniques or certain things that we don't offer because they're so rare, and they're usually
Mhm.
in a research
Mm,
situation.
right.
Yeah.
So they're asking for, oh, do you guys do this or do you do that? No, we don't do that,
Mhm.
And usually that's more in a research setting.
Yeah.
It's not to say that we don't do it. I mean,
Mhm.
we just picked up a research study and for the brain. And even though there's one technique that we don't do within that research study,
Mhm.
we're still going to do the research study without that one technique that they were
Mm.
Mhm.
asking for.
Yeah.
So it's still going on. It's still, we just got approved for it. Everything was good. Submitted everything. So
Yeah.
That's exciting for you to learn more
yeah,
about, the things that we don't do. So then maybe in the future we do
yeah,
offer it. You're
yeah,
already ahead of the game.
yeah. But you also have to remember, we if there's not a huge market for
Mhm.
that, then it's hard for us to say, is it conducive for us to
Mhm.
have that?
Yeah.
Yeah.
Where we've had things like what they were looking for, like DTIs or something like that, diffusion tensor imaging, where we have to buy the equipment, we have to do all that
Mhm.
stuff. It costs a lot of money. Is it really conducive to our facility to
Mhm.
purchase something like that if we're going to do 2 or 3 of those a year?
Yeah.
Mm.
Then it's really not the place for us. They can probably find a setting where a lot of people do a lot more of
Yeah.
those.
And I would imagine as the tech, it's probably hard to perfect or even remember how to do a
Yeah,
study if you're doing it 3 times a year.
yeah,
Mhm.
exactly. And so that's what happens a lot of
Yeah.
times. So it's comes down to, like, we do this knee study that everybody that I've taught, well, they're gone, long gone,
Uh-huh.
Mhm.
because I haven't done this particular knee study in
Mm.
probably 2 years.
Yeah.
And then it shows up again, and Tom, you know how to do this, right? And I'm going,
I
yeah.
did know how to do
Yeah,
that. Let me
exactly.
find it in my brain somewhere.
And then you go get the stuff and you start reading it over. Go, yeah, I remember how to do it.
Yeah, it's coming back to me
It's
now.
coming back, and then they'll book it or something like that. Those things. Yeah, you're right.
Yeah.
And then they get the call. They'll say only schedule it when Tom's around,
Yes.
Yeah.
and there's a reason. It's because I'm probably the only one that's ever done it before, but
Yeah.
it doesn't mean I remember how to do
Yeah.
it. But, it's been a couple of years.
Yeah.
So, yeah, those things, that happens
Yeah.
sometimes.
So I know you said that you started an MRI kind of in its infancy.
Yeah.
How has it changed the most?
Um,
I'm sure a lot of it has changed, but what's like your biggest?
the types of exams that we can do now,
Mm.
the things that we can see, the types of pathology that we can show, we can see, and the speed. Um, really comes down to the speed. Before, when I first got into it, you would do a lumbar spine with 3 sequences, which was or 4 sequences, which was a T1 sagittal, a T2 sagittal, and a T2 axial. And it would take almost an hour to do those 3 sequences.
Wow.
Now, we can do a T1, a T2, a PD, a sagittal, a stir sagittal. Well, these are all different types of techniques.
Mm-hmm.
And then a T1 and T2. And we can get them all axial, and we can do all of that in about 15 minutes. We can do
Wow.
like 5 sequences rather than just 3
Mm.
in 15 minutes rather than only 3 sequences in an hour.
Wow.
That's
That-
improved a lot.
That's beneficial to everybody,
Yeah.
especially the patient who doesn't have
Oh
to
yeah,
sit in there
they
for
have
so
to
long.
sit there. And not only that, you got to remember sometimes a sequence would take 12 to 15 minutes to do
Mm.
one sequence. As far as technique,
Mhm.
if you're doing a sequence that takes 12 to 15 minutes, now that same sequence can take 2 minutes.
Wow.
So, you would set up and you would have to sit there and just,
Yeah.
I read a lot of books.
Yeah. Oh my gosh.
Because you're sitting there doing nothing and you're just going, okay, might as well read a book.
Yeah.
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 So, and yeah, a lot of MRI techs would bring books with them because it was that long,
Oh, wow.
when you would set up the scan, you plug it in, you hit play, and you start going, and the hardest part is that think about not moving for 15 minutes.
Oh, the poor patient.
So you're going to get blurry pictures. So then you have to repeat them.
Oh my
Mhm.
gosh.
So, back in the day, it was, in its infancy, it was a lot harder, it comes to now 2 minutes, it's only 2 minutes,
Yeah.
hold real still.
That's probably also why patients, older patients who've had them done before are
Yeah.
always like, oh, it takes forever. And that's why they have the review that they have, because it did take a long time.
Yes. Yeah.
And they are the ones that are telling the next generation, the generation after that, what an MRI is and was.
Yeah. And a lot of times, a lot of patients confuse CT with MRI.
Mhm.
Yeah.
Where a CT, you're going in there, boom, zoom, you're done.
Yeah.
And then all of a sudden they're sitting there and they're going, how much longer? It never took me this long before. You guys, I've been here before and you've done it. And then you look at their history and they go, no, they had CTs.
Yeah.
And so they go, no, this is an MRI. It's a little bit different than a CT. MRIs take a lot longer
Yeah.
than a CT scan. So they might mix those up.
Yeah. They're like, an exam is an exam is an exam, and I've done this before.
Exactly. They just see a big tube type donut or whatever, and they're going in it and coming out and thinking that, oh, that's
Same thing.
yeah.
Mhm.
And why is it this much louder?
Mhm.
And I go, well, it's probably because you had a CT scan, and CTs are much quieter than MRIs.
Yeah.
MRIs are
Like the
longer
machine's
and
broken.
noisier.
Yeah. Something's wrong with your machine.
Or my biggest thing is most people say this sounds like a bad techno
Oh.
concert.
And I love techno, so it'd be fine. If you weren't going to be working in MR, what other profession would you have chosen?
You could do anything in the
Yes.
world.
Anything in the world.
Yes.
Well, number one, I'd be a musician. That's what I do on my side.
Yeah.
I'm a drummer and I have playing a band and I do that.
What's
What
the
is
name of your band?
Yes.
It's called Mixed Generations.
Oh.
And the reason why it's called Mixed Generations is because one member, the keyboardist, he's in his 70s,
Okay.
and the youngest person is in his early 30s.
Oh.
So, and everybody in between.
How
Mm.
fun. What
So
kind
it's-
of music do you play?
We just pretty much cover tunes like, anything from the 70s to today.
Oh.
Really?
Yeah.
That's fun.
Nice.
How do
Yeah.
we book you?
Like where?
Just call me.
You're like, send me an email.
I was like, do you guys have like an Instagram handle? Where can we like see where you're playing?
We're in the middle of trying to get an Instagram handle
Gotcha.
together.
Stacy's your social media girl.
There you
need
go.
help, ask Stacy.
That sounds good. I might have to hit you up, Stacy.
How long have you been playing the drums for?
Since I was 14.
Wow.
That's a long time.
Long time.
It's a
I was
very-
banging
We
around.
gotta have
Yeah.
like
I
we
was-
gotta listen to you.
I
We
was-
gotta hear you play.
I was playing. I just remember setting up pots and pans when I was a little kid with my mom and hitting them with wooden spoons.
Oh, your poor
Oh.
mother.
Maybe she liked
Want
it.
to be a drummer.
Oh, that's cool.
Yeah. And then the other, I did leave the medical field for a little while.
You did.
Well, not really. I never left. I
You
should
left.
say.
You went on a hiatus.
I would work here and there. I'd cover shifts for friends or whatever.
Mhm.
I'd do a lot of per diem work. But I was a financial advisor for about 10 years.
Wow.
Yeah.
I feel like you do everything.
I've done a lot of things.
Like the more I learn about you, I'm like, he's a drummer. He likes to. I mean, you teach. You obviously do MRI. Now,
Yeah.
financial advisor. I'm like, I need to call you for a lot of things right
Yeah.
now.
What can you not do?
Yeah. Yeah.
Well, call my wife. She'll tell you.
He can't cook. Put his
Actually,
clothes
I
away.
do the cooking.
Oh
at
my
that.
gosh.
Oh man.
Of course.
But no, my wife is always telling me, I need to talk to my financial advisor because my stocks aren't doing too well right now. I go, okay.
That's fascinating. Oh, Tom. Well, thank you, Tom, for joining us. And thank you for tuning into the Healthy Image podcast. We want to give a big thank you to you, Tom,
Thank
one of
you.
our favorite MRI technologists here at the Huntington-Hill Imaging
best.
Center. Thank you for taking us behind the scenes of the scanner and sharing the heart precision and teamwork that go into every exam. You know, conversations like this remind us that imaging is more than technology. It's about people, patient comfort, and delivering answers that help guide care forward. If you found this episode helpful, be sure to share it with a friend, a colleague, or anyone who might find this helpful. Like, subscribe, leave us a comment or a message if there's, something you want to hear. Just let us know. And as always, stay curious, stay engaged, and stay healthy. Bye.
Bye.